Welcome back to the Hypokalemia series. In episode 1, we built the diagnostic framework, the three door model, renal loss, extrarenal loss, and transcellular shift. And we identified the urine potassium to creatinine ratio as our sorting hat with a threshold of 15 millicoulomb per gram. Today, we are going deep on that third door, transcellular shift. This is the sneaky one because labs can trick you. Urine potassium is low, which makes you think, oh, this must be a GI loss. But it's not. The potassium hasn't left the body, it's just moved from outside the cell to inside the cell. And here's why this matters so much clinically. If you treat a transcellular shift like a true deficit, if you aggressively replete potassium in someone whose total stores are completely normal, you are adding potassium to a body that doesn't need it. You are overfilling the tank. And when the trigger resolves, the insulin wears off, the refeeding stabilizes, whatever it is, all that potassium comes flooding back into the extracellular space, plus the extra you added. You get rebound hyperkalemia, and that can cause fatal cardiac arrhythmias. So, knowing that you are dealing with a shift and not a true deficit changes everything about how you manage the patient. Cautious repletion only, and treat the underlying cause. Now, what are the triggers that drive potassium into cells? There are four major ones you need to know. There are four major triggers that drive potassium into cells. All of them ultimately work through the same final common pathway, activation of sodium potassium ATPase on cell membranes, particularly skeletal muscle. Let me walk you through each one. First, thyrotoxicosis. In hyperthyroidism, there is increased responsiveness to beta adrenergic stimulation. This overstimulates the sodium potassium ATPase on skeletal muscle membranes, driving potassium into cells. And the result can be dramatic. Potassium levels below 2.0 with acute paralysis. This is thyrotoxic periodic paralysis, and we are going to go spend a lot of time on it today because the boards love it. Second, insulin and carbohydrate loading. When you eat a big carb heavy meal, insulin is released, and insulin directly activates the sodium potassium ATPase. Now, here's what's interesting. This is actually a normal physiologic mechanism. Your body does this to prevent postprandial hyperkalemia. Every time you eat, potassium shifts into cells a little bit. But in certain patients, those with periodic paralysis, this normal response becomes pathologically exaggerated, and the potassium drops dangerously low. This is also the mechanism behind the DKA paradox, which we'll get to shortly. Third, catecholamines and beta agonists. Epinephrine, albuterol, any beta 2 agonist. They activate the sodium potassium ATPase and drive potassium into cells. And this is clinically relevant. I've seen patients getting continuous albuterol nebs for asthma exacerbations whose potassium drops to the twos. Stress, whether physiologic or emotional, causes catecholamine release and can do the same thing. And fourth, refeeding syndrome. This is the scenario where a chronically malnourished patient, an alcoholic, an anorexia patient, someone just hasn't been eating, gets fed aggressively. The sudden carbohydrate load triggers a massive insulin surge, and sodium and potassium, phosphorus, and magnesium all crash simultaneously. We'll go through a classic case of this later. Now, let me start with first trigger in detail, thyrotoxic periodic paralysis. Let me walk you through a classic case. A 35-year-old Japanese man comes to the ED with sudden onset lower extremity weakness. He went jogging that morning, then had a big breakfast of pancakes and fruit, and about an hour later, he couldn't get out of his chair. His potassium is 1.7. 1.7. That's profoundly low. Before you even look at the urine, there are clinical clues screaming at you. He has tachycardia at 105, mild proptosis, that's eye bulging, a fine resting tremor. He's been having heat intolerance, sweating, and frequent bowel movements. These are all signs of thyrotoxicosis. And the presentation, acute paralysis after exercise and a carbohydrate load in a young Asian man. This is thyrotoxic periodic paralysis. The urine potassium will be low because this is a shift, not a renal loss. The kidneys are doing their job conserving potassium in the setting of hypokalemia. So here's the physiology. Thyroid hormone excess increases the responsiveness of tissues to beta adrenergic stimulation. This overstimulates the sodium potassium ATPase, particularly on skeletal muscle membranes, driving potassium into cells. The triggers are things that further activate the sodium potassium ATPase or increase catecholamine drive. Exercise, which releases catecholamines, stress, and high carbohydrate meals, which trigger insulin release. Those pancakes triggered an insulin surge on top of the already heightened beta adrenergic state, and the potassium crashed. Key demographics: thyrotoxic periodic paralysis has roughly a 20 to 1 male to female ratio, and the prevalence is highest in Asian populations, particularly East Asian. But, and this is important, it can happen in anyone with thyrotoxicosis. There's even been a case report of someone developing it from taking exogenous thyroid hormone. For acute management, cautious potassium. Remember, total body potassium is normal. Don't overshoot. And propranolol, which blocks the beta adrenergic drive, feeding the shift. But the definitive treatment that prevents recurrence is treating the underlying hyperthyroidism. Methimazole for Graves' disease, or whatever the appropriate therapy is. Once the patient is euthyroid, the periodic paralysis stops completely. Now let me compare this to the familial form. Here's the side-by-side comparison you need to have locked in for boards. Thyrotoxic periodic paralysis is acquired. It comes from hyperthyroidism. Familial hypokalemic periodic paralysis is inherited, autosomal dominant, caused by mutations in skeletal muscle ion channels. About 70% of cases involve CACNA1S, a calcium channel subunit. Less commonly, it's SCN4A, a sodium channel. Thyrotoxic periodic paralysis tends to present between ages 20 and 40, and it's overwhelmingly an Asian male disease. Familial HPP presents earlier, usually before age 20, and is more common in Caucasians. The triggers are identical: exercise, carbs, stress, because the final common pathway is the same. And the urine potassium is low in both, because both are transcellular shifts. But the treatment is completely different. For TPP, you treat the thyroid, methimazole, and use propranolol as a bridge. For familial HPP, since there is no thyroid disease to fix, the prevention strategy is acetazolamide, a carbonic anhydrase inhibitor. Three small randomized trials have shown it reduces attack frequency. And here's a board point: patients with CACNA1S mutations respond better than those with sodium channel mutations. And see that warning at the bottom. Hydrochlorothiazide is used for hyperkalemic periodic paralysis, a completely different entity. If you give a thiazide to someone with hypokalemic periodic paralysis, you'll make things worse. Know which is which. All right, this is a board trap that shows up in various forms, and I want to make sure you don't fall for it. Here's the setup: a patient eats red licorice, then develops hypokalemia. Your first instinct might be licorice. That's glycyrrhetinic acid that inhibits 11 beta hydroxysteroid dehydrogenase type 2. That's apparent mineralocorticoid excess. But here's the thing: red licorice is not actual licorice, it's just candy flavoring. It contains zero glycyrrhetinic acid. The real clue is in the urine. If the urine potassium to creatinine ratio is low, below 15, this is not renal wasting. It's a transcellular shift. And if the patient has thyroid symptoms, tachycardia, tremor, heat intolerance, the answer is thyrotoxic periodic paralysis, with the red licorice as a complete red herring. Now, black licorice, the real stuff from the Glycyrrhizia glabra root that does contain glycyrrhetinic acid, and it does cause apparent mineralocorticoid excess with hypertension, renal potassium wasting, and metabolic alkalosis. But that's a different episode. The takeaway: always check the urine potassium before jumping to a diagnosis. Now, let me shift gears to a scenario that combines both a transcellular shift and a true deficit. And it's one of the most dangerous situations in all of medicine. Think about what's happening in a diabetic ketoacidosis. You've got three independent forces that should all be pushing potassium out of cells and into the serum. First, acidosis. When the blood is acidic, hydrogen ions move into cells and potassium moves out to maintain electroneutrality. So, acidosis should raise serum potassium. Second, insulin deficiency. The sodium potassium ATPase needs insulin to function optimally. Without insulin, potassium doesn't get pumped into cells as efficiently, so it stays extracellular. Third, hyperosmolality. The extremely high blood glucose, we are talking in 900 in the case, creates an osmotic gradient that pulls water and potassium out of cells by solvent drag. All three of these forces should make the serum potassium high. And in fact, many DKA patients do present with normal or even elevated potassium. But what if it is low? What if the potassium is low? What if, despite acidosis, despite insulin deficiency, despite hyperosmolality, all three forces pushing potassium up, the serum potassium is still below 3.5? Think about what that means. If three independent forces are all pushing potassium out of cells and the level is still low, the total body deficit must be absolutely enormous. These patients have been losing potassium for days, sometimes weeks, through osmotic diuresis. The high glucose causes glycosuria, which pulls water and electrolytes with it. By the time they present, their potassium reserves are depleted. And here's the life or death management pearl. Do not start insulin until the potassium is above 3.3 milliequivalents per liter. Some guidelines say 3.5. I know the instinct is to start the insulin drip immediately. The patient is in DKA, the glucose is 900, they are acidotic, but insulin will activate the sodium potassium ATPase and drive that remaining extracellular potassium into cells. The serum potassium will crash and you can get fatal cardiac arrhythmias. Fluids first, potassium first, then insulin, and monitor potassium every 1 to 2 hours because it will drop rapidly once the insulin is running. And here's the classic refeeding scenario. A 45-year-old man with alcohol use disorder is in the ICU for community acquired pneumonia. His BMI is 17.5. He is clearly malnourished. Been on the streets, not eating well for who knows how long. He's intubated, and on day 2, the team starts nasogastric tube feeding. Good intentions. But 2 days later, his potassium drops from 4.5 to 2.7, and he develops non sustained ventricular tachycardia on telemetry. His urine potassium is 10 milliequivalents per liter. That's appropriately low. The kidneys are conserving. This is not renal wasting. This is a transcellular shift. What's happening? The sudden carbohydrate load from the tube feeds triggers a massive insulin surge. Insulin activates sodium potassium ATPase and drives potassium, phosphorus, and magnesium into cells. All three drop. You can see the trifecta here. Potassium crashed, phosphorus is 1.9, and you need to be watching the magnesium like a hawk. And in and the board question asks what would best address the cause of hypokalemia? And the answer is decrease nasogastric feeding rate. No, not more potassium. Decrease the feeds. The treatment for refeeding syndrome is not to just give more potassium and keep feeding at the same rate. The treatment is to decrease the feeding rate. Start nutrition slowly. The goal is to meet full caloric requirements within 4 to 7 days, not on day 1. And here's an important step that gets missed. Before you even start feeds in a malnourished patient, give thiamine because refeeding can also precipitate Wernicke encephalopathy if thiamine stores are depleted. During feeding, monitor potassium, phosphorus, calcium, and magnesium closely, sometimes every 6 to 8 hours in the first few days. Replete aggressively as needed, but keep the feeding rate gradual. Who's at risk? Anyone who has been starving, alcoholics who haven't been eating, anorexia nervosa patients, elderly patients who stopped cooking for themselves, cancer patients with prolonged poor intake, prisoners on hunger strikes. If the BMI is below 18.5 and they haven't been eating, assume refeeding risk. Here's your rapid recall table for the 4 major transcellular shift scenarios. A few things to highlight. First, urine potassium is low in thyrotoxic periodic paralysis, familial hypokalemic periodic paralysis, and refeeding because these are pure shifts. In DKA, it's variable. The patient may actually have ongoing renal potassium losses from osmotic diuresis, so the urine potassium might be elevated. That's because DKA is both a shift and a true deficit. Second, Total body potassium is normal in thyrotoxic periodic paralysis and familial hypokalemic periodic paralysis. That's why cautious repletion is the key to avoid rebound hyperkalemia. In DKA and refeeding, there is actual depletion on top of the shift, so you do need to replete, but intelligently. Third, the prevention strategies are completely different for each one. Methimazole for TPP, acetazolamide for familial hypokalemic periodic paralysis, prevent DKA through diabetes management, and start feed slowly for refeeding. That's a transcellular shift episode. The key takeaway: when the urine potassium is low, look at the clinical context. Is there thyrotoxicosis? That's TPP. Treat the thyroid. Is the patient young, euthyroid with recurrent episodes triggered by carbs or exercise? That's familial hypokalemic periodic paralysis. Acetazolamide for prevention. Is the patient in DKA with a low potassium? That's massive depletion, potassium before insulin. Is the patient malnourished and being fed? That's refeeding, slow down the feeds. Next episode, we are going into Bartter and Gitelman syndromes. These are the salt wasting tubulopathies that cause hypokalemia with metabolic alkalosis. I'll teach you the calcium trick, the one test that lets you tell them apart at the bedside. Bartter has hypercalciuria and nephrocalcinosis. Gitelman has hypocalciuria. It's elegant physiology, and it all comes down to where in the nephron the deficit is. Thanks for watching. See you in the next one.